Acute hypoxia. Depending on how quickly and intensely the stress is in labor, we have different types of hypoxia. Today, we'll be speaking about acute hypoxia when the stress starts acutely and intensely. During these next 10 minutes, we'll be learning to identify acute hypoxia on the CTG, to understand and identify the most common causes, and we will present an easy way to manage acute hypoxia without panicking. So, how to identify acute hypoxia is very simple. It's a single prolonged deceleration with a sudden drop in baseline fetal heart rate persisting for more than 3 minutes. Remember that the hypoxic stress is intense, starts quickly, so the pH drops rapidly at about 0.01 per minute, with metabolic acidosis developing quickly. So the key question is, why is the baby doing this? What is the cause of this acute stress? It's easier if you consider two groups of causes, the irreversible ones and the reversible ones. Irreversible causes would be abruption, cord prolapse, and scar rupture. On the other hand, you can also have reversible causes that are also most common, like hyperstimulation, cord compression, or hypertension. Let's present a management algorithm so you can work step by step, starting to exclude the irreversible causes: abruption, cord prolapse, or scar rupture. So always take in account the patient and the overall circumstances. Is there a history of a previous cesarean section or myomectomy? A recent artificial or spontaneous rupture of membranes with a high presentation? Or do you have any signs of abruption like bleeding? If you have any irreversible cause, then you need to move quickly and to deliver the baby by the safest and quicker way. If you don't have full dilatation, you need to prepare for a surgical delivery. Once you have excluded the irreversible causes, then you need to think if there's anything you can correct. Think about uterine hyperstimulation, maternal hypertension, or cord compression. Especially if you are in the context of epidural top-up, maternal hypertension is a very plausible cause. If you are using oxytocin or prostaglandins, uterine hyperstimulation would be one of the most common reasons. How can you correct the reversible causes? Easy. Once you identified what is the cause, if it's uterine hyperstimulation, stop oxytocin or consider a tocolytic like terbutaline at the doses of 250 micrograms subcutaneously. If you have maternal hypertension, increase the IV fluids, or cord compression you can easily correct by changing maternal position, usually to the left lateral. Step 3 would be to look carefully at the CTG, identifying reassuring features. If the CTG is normal prior to this deceleration, and if you have normal variability within the 3 minutes of deceleration, it is likely that the baby will recover within the next 6 or 9 minutes. You probably heard about the rule 3-6-9-12. This rule should only be applied if you have, by 3 minutes, excluded the irreversible causes, because in that circumstances you should not wait: cord prolapse, scar rupture, or abruption. By 6 minutes, you should have corrected the reversible causes: hypertension, hypertonia, or cord compression. By 9 minutes, you should have some signs of recovery, in which case, if they are not present, you should start preparing for delivery so you can have delivery completed by 15 minutes. as a take-home messages, acute hypoxia is a sudden drop on the fetal heart rate that lasts for more than 3 minutes. Remember that you have reversible and irreversible causes, and your management will be mostly dependent on the identification of what is the cause for the prolonged deceleration. And the management will be accomplished by steps. And remember also to look at features on the CTG that will help you to either be more reassured if you have normal CTG prior to the deceleration and normal variability within the 3 minutes, or the non-reassuring features where you have a pathological trace before the deceleration, you have very reduced variability within the first 3 minutes, and you do not have any signs of recovery by 6 or 9 minutes. Let's look at some examples. Consider that this patient is a primip, 39 weeks. She has been low risk antenatally and she came to your labor ward in spontaneous labor. She has an epidural sited and oxytocin infusion was started for slow progress at 6 centimeters. Now, what is the type of hypoxia? How much is the pH dropping? What do you think is the more likely cause or causes? What would you do? And what reassuring signs do you see on this CTG? This is certainly an acute hypoxia. It's a prolonged deceleration that is lasting now for 3 minutes. You know that metabolic acidosis develops rapidly in acute hypoxia at about 0.01 every minute. In this case, you need to consider the oxytocin bolus. Remember that on the tochocardiograph, what you see is the number and duration of the contractions. You can't assess intensity. So even if you see only one contraction, you need to use your clinical skills to assess if you have hypotonia. Consider also, since she's having an epidural, and especially if a recent top-up has been used, if you have maternal hypertension. So the key things here will be to stop the oxytocin, to consider terbutaline, to use IV fluids, change position, and since you have reassuring signs on the CTG, it was normal before, and you have a normal variability within the first 3 minutes, you know that the likelihood of recovery is very high. Let's look now at example 2. You have a multip in labor. She had a cesarean section and 1 vaginal delivery in the past. This labor has been induced at 40 weeks for maternal age with artificial rupture of membranes and oxytocin infusion. There's an epidural sited and you have been noticing that the liquor is blood stained. Suddenly, the fetal heart rate drops. Consider now, what type of hypoxia? What is the most likely cause, or at least the one you need certainly to exclude? What are the CTG features that support your hypothesis, and what would you do next? In this case, you need to consider scar rupture. There's a history of a previous cesarean section. You have noticed blood-stained liquor. You can see that the CTG before shows a saltatory pattern with increased variability, and you can see that in the first 3 minutes, the variability is very reduced pencil tip type. So call for help, stop the oxytocin, do your clinical assessment, and move to theatre, including your team, the anesthetic team, your midwife coordinator, and the neonatologist. In these cases, you should not wait. This is the time to run. So once more, most of the times acute hypoxia is due to reversible causes. It's key to understand why is the sudden drop of the fetal heart rate happening, to exclude the major intrapartum accidents, because those are the ones that you need to act quickly and deliver by the safest and quickest way: cord prolapse, abruption, and scar rupture. Most of the times you'll be facing reversible causes that you can help correcting, like hypertonia, maternal hypertension, or cord compression. The same way, most of the times the baby will recover by 9 minutes, in which case there is no need to panic. Certainly, it will not be necessary to perform a cesarean section for a situation that will correct in the first 9 minutes.